Welcome back to the weekly Neurology Deep Dive. We're the show that aims to unpack complex clinical research and translate it into usable insights for your practice.
We're produced by Amir Gavanini.
And today we're diving deep, really deep, into idiopathic normal pressure hydrocephalus. It's a condition that, as many of you know, can be incredibly challenging to diagnose, especially in older adults.
Absolutely. And that diagnostic challenge often leads to delays, sometimes misdiagnosis, maybe even unnecessary procedures. So our goal today is to synthesize the crucial data we have now.
We'll be looking at everything from population studies showing perhaps higher incidence than we thought, to international guidelines trying to standardize things like the TAP test, and even level 1 randomized evidence on treatment effectiveness.
It's about giving you a comprehensive picture diagnosis, the variability in treatment response, prognosis based on the latest research.
Okay, before we get into the weeds, we need to state our standard disclaimer. This deep dive is purely for educational purposes.
That's right. There's no commercial goal here. We're summarizing research findings.
And we really do recommend you go back and read the original papers yourselves for the full context and detail.
Definitely. Now, for those of you short on time, the busy neurologists tuning in, we've distilled the key clinical takeaways right here at the start. We'll elaborate on the evidence behind these throughout our discussion.
Okay, point 1. Keep idiopathic normal pressure hydrocephalus high on your differential. The prevalence seems significantly higher than older estimates suggested. We're talking recent incidence figures around 4.8 cases per 1,000 person years in older adults.
Second takeaway. Look beyond the classic Evans index for imaging. It's just not specific enough on its own. Newer markers, particularly the Z-Evans index and the callosal angle, are much more powerful predictors of disease development.
Third, the large volume cerebrospinal fluid TAP test. It desperately needs standardization. The current expert consensus points towards removing a minimum of 30 milliliters of cerebrospinal fluid.
Ideally targeting 40 to 50 milliliters. And the key objective outcome you're looking for, greater than about 25% improvement in gait velocity, measured using the 10-meter walk test.
Fourth point, and this is a tough one. Treatment failure is common, and it's variable. About 54%, that's over half of patients who get a ventriculoperitoneal shunt, are early non-responders.
And crucially, trying to adjust the valve settings later on doesn't seem very effective for that group.
And finally, the fifth takeaway comes from the highest level evidence we have, the PENS trial. It confirms ventriculoperitoneal shunting does significantly improve gait and balance.
But, and this is important, that benefit doesn't necessarily carry over to cognition or urinary incontinence, at least not significantly at the 3-month follow-up point.
Okay, so that's the snapshot. Let's spend the rest of our time unpacking the data behind these points. Part 1. Epidemiology and those predictive imaging markers.
Right. The whole idea that idiopathic normal pressure hydrocephalus might be significantly under-recognized really gained traction with studies like the prospective longitudinal cohort study from Gothenburg, the age 70 birth cohort study.
That Gothenburg study provides some really solid population-based numbers, doesn't it? What did it reveal about the true incidence?
Well, they followed a cohort of individuals for 6 years, starting when they were around 71 years old on average. And the incidence rate they found was, frankly, startling, about 4.8 cases per 1,000 person years.
4.8 per 1,000. How does that compare to what we thought previously?
If you compare it to, say, similar community-based studies from Japan, this rate is roughly 4 times higher. 4 times.
Oh, that's a huge difference. It really implies we might be missing a lot of cases or maybe misdiagnosing them as Parkinson disease or vascular dementia, things like that.
Exactly. A 4-fold difference really forces us to reconsider how we screen for this, particularly in primary care and even general neurology clinics.
Did the study also look at prevalence changes over time, since it's often seen as an age-related condition?
Yes, and the prevalence data backs that up. Over the 6-year follow-up period, the prevalence of possible idiopathic normal pressure hydrocephalus basically doubled. It went from about 1.5% at baseline when the average age was 71, up to about 2.9% when the average age hit 77.
Doubling in just 6 years really highlights the need for ongoing monitoring as people age, doesn't it?
It certainly does. And what's perhaps even more critical for us as practicing neurologists is understanding the progression risk from those preclinical stages. You know, when we see ventricular enlargement incidentally on magnetic resonance imaging done for other reasons.
Right. The study looked at people who just had the radiologic signs, what they called asymptomatic ventriculomegaly, with features of normal pressure hydrocephalus on magnetic resonance imaging. How likely were they to actually develop the clinical syndrome?
The risk was remarkably high. Of those individuals with only the imaging markers at baseline, about 43% progressed to meet criteria for definite or probable idiopathic normal pressure hydrocephalus within those 6 years.
Almost half. That's significant. What if they had some mild, isolated symptoms along with the imaging findings? Say, just a bit of gait trouble, but not the full triad.
Then the risk climbed even higher. For those participants with both the radiologic features and some isolated symptoms, about 67% progressed to possible idiopathic normal pressure hydrocephalus over the 6 years.
Two-thirds. These numbers are really compelling. They argue strongly for paying close attention to these preclinical or early symptomatic stages, maybe even considering intervention earlier.
Precisely. It shifts the focus towards active monitoring and potentially proactive management.
Were there any baseline characteristics or risk factors identified in the Gothenburg study that helped predict who might develop idiopathic normal pressure hydrocephalus?
Yes, some baseline factors did show predictive value. Interestingly, a higher baseline body mass index was significantly associated with an increased risk of developing the condition.
Higher body mass index, increased risk. Any protective factors?
Conversely, things indicating better physical function seemed protective, better performance on the one-leg static balance test at baseline, and higher scores on the total score on the Hellstrom Idiopathic Normal Pressure Hydrocephalus scale, which reflects overall better function, were both associated with a significantly lower risk progression.
So basic measures like balance might actually be useful negative predictors.
It seems that way, yes. Good balance, better overall scores on that scale associated with lower risk.
Okay, so if we know that a large portion of people with the right imaging signs will progress, the reliability of those imaging signs becomes absolutely crucial. You mentioned earlier we need to move beyond the standard Evans index.
Absolutely. The Gothenburg study really quantified this. While the Evans index is familiar, its predictive power wasn't the best. The marker that came out on top was the callosal angle.
The callosal angle. How strong was its predictive performance?
It demonstrated the strongest performance for predicting idiopathic normal pressure hydrocephalus development, achieving an area under the curve of 0.93. Remember, 1.0 is perfect prediction, so 0.93 is very impressive.
And what was the optimal cutoff they found for that angle?
The optimal cutoff identified in that study was 112 degrees.
An area under the curve of 0.93 with a clear cutoff. That sounds clinically useful. How would you apply that?
It gives you a high degree of confidence. Imagine a patient comes in with gait issues, you get a magnetic resonance imaging, and their callosal angle is, say, 105 degrees, well below that 112 cutoff. That significantly increases your certainty that you're dealing with true idiopathic normal pressure hydrocephalus, not just age-related changes. It offers about 93% predictive accuracy based on this data.
Were there other useful radiologic markers, maybe simpler ratios?
Yes, a couple of others performed very well, too. The Z-Evans index and the brain-per-ventricle ratio at the anterior commissure both achieved an area under the curve of Mort 90.
Okay, Mort 90 is also quite strong. What were the cutoffs for those?
For the Z-Evans index, the optimal cutoff was found to be 0.31. And for the brain-per-ventricle ratio at the anterior commissure, it was 1.49.
Let's focus on the Z-Evans index for a second. Why is it better than the standard Evans index we typically use, the simple ratio of frontal horn width to inner skull width?
It boils down to specificity. The standard Evans index cutoff, usually greater than 0.3, is just too common in the general older population. The Gothenburg data showed that about 25% of participants without idiopathic normal pressure hydrocephalus actually met that 0.3 cutoff.
So a lot of false positives if you rely only on the standard Evans index.
Exactly. It lacks specificity. The Z-Evans index improves on this because it essentially normalizes that ventricular size ratio, accounting for expected age-related changes and normal population variance. This makes it a much more specific indicator of pathological ventricular enlargement.
So the clinical message here is, prioritize using these refined metrics, the callosal angle and the Z-Evans index over the traditional Evans index for better diagnostic accuracy.
That's the key takeaway from the imaging data, yes.
Yeah.
It helps select the right patients for the next step.
Which brings us neatly to part 2, standardizing the large volume cerebrospinal fluid TAP test. We have good imaging markers to raise suspicion, but the TAP test is still our main physiological test, right? But its methodology has historically been, well, all over the place.
It's been a bit of a mess, frankly, and that's exactly why the International Parkinson and Movement Disorders Society Normal Pressure Hydrocephalus Study Group, the MDS-MPH group, did their systematic review. When you see published sensitivities ranging from about 72% all the way up to 100%, and specificities from about 33% to 100%, you know the lack of a standard method is causing huge problems.
Massive variability. So what did the MDS-NPH group recommend to bring some consistency? They looked at volume, timing, and outcomes, right?
Correct. Let's start with the volume of cerebrospinal fluid to remove. What's the consensus now?
Based on their review of what was actually being done in published studies, the recommendation is to remove a minimum of 30 milliliters.
Okay, a minimum of 30. Why that specific number?
Well, the data showed that about 94% of the studies they reviewed removed at least that much. So it seems to be a widely accepted floor in practice. However, they suggest an optimal range, and that optimal range is
30 to 50 milliliters.
why the range, 30 to 50, rather than a single number like, say, 40 milliliters? Is the evidence not clear on the ideal volume?
The consensus group acknowledged that while 30 milliliters is the minimum, we actually need more research to definitively say if removing 40 versus 50 milliliters offers a significant diagnostic advantage, especially for maximizing the response you see.
So for now, the practical advice is,
Aim for the higher end of that range, maybe 40 to 50 milliliters, to ensure you're giving the patient the best chance to show a response.
okay, volume sorted. What about the timing of the assessment after the tap? This seems crucial for catching responders.
Absolutely critical. The recommendation is to perform the initial assessment sometime between 3 and 24 hours after the lumbar puncture. That window should capture most immediate responders.
But we know some patients respond later, don't we?
Exactly. And the guidelines strongly emphasize this. If you don't see any clinical improvement within that first 3 to 24-hour window, you must repeat the assessment again at 48 hours post-tap.
Don't stop at 24 hours if the initial assessment is negative.
Correct. You risk missing those delayed responders who might still benefit from a shunt if you don't do that 48-hour check.
Now, a practical point. The type of needle used for the lumbar puncture, atraumatic versus conventional. Does it matter for the tap test results or just for complications?
Interestingly, the systematic review found a gap here. There wasn't specific data in the reviewed literature comparing needle types specifically for the high-volume tap test, so the recommendation is mainly driven by minimizing complications.
And what's the complication difference, primarily post-lumbar puncture headache?
Yes. The recommendation favors using an atraumatic needle if you have one available, simply because it's associated with a lower rate of post-procedural headache. The numbers suggest headaches occur in only about 4% of cases with atraumatic needles, compared to about 11% with conventional needles.
That seems like a clear reason to prefer atraumatic needles. Is there any counter-argument?
Well, there's a bit of a clinical nuance, or perhaps debate. Some experts theorize that a conventional needle, by potentially allowing a tiny, usually non-problematic cerebrospinal fluid leak, might actually enhance the sensitivity for detecting those delayed responders.
An interesting thought, but probably not enough to outweigh the lower headache risk for most clinicians.
Probably not, unless you have a very, very high index of suspicion and the initial tap with an atraumatic needle was negative. Most will likely opt for the lower complication profile.
Okay, let's get to the core of the tap test, the clinical assessments. Gait is king here, right? What specific tests should we use, and what's the magic number for improvement?
Gait is definitely the primary outcome measure. The review found the timed up and go test was used most often in the literature, about 68 articles. The 10-meter walk test was also very common, used in about 49 articles.
So which one does the consensus recommend?
They explicitly recommend recording gait velocity using the timed 10-meter walking test.
Gait velocity from the 10-meter walk test, and the critical threshold for defining a positive response.
The primary definition of a positive tap test indicating shunt candidacy is observing greater than about 25% improvement in that gait velocity compared to the baseline measurement before the tap.
Greater than about 25% improvement in gait velocity. That's the key objective target.
That's the number. If you hit that, you have solid short-term evidence suggesting the patient's mobility issues are pressure-related.
What about the other parts of the triad? Cognition first. Many use the mini mental state examination. Is that adequate?
The review confirmed the mini mental state examination is the most frequently used screen. However, the MDS-MTH group recommends using the Montreal Cognitive Assessment as the minimum standard.
Why the preference for the Montreal Cognitive Assessment?
Because it does a better job of assessing frontal executive functions, things like planning, attention, fluency, which are typically the main cognitive deficits in idiopathic normal pressure hydrocephalus. The Montreal Cognitive Assessment includes tasks like clock drawing and phonemic fluency that tap into this more effectively than the mini mental state examination's orientation focus.
And if you want to delve deeper into cognition, any other recommended tests?
For a more thorough assessment, they suggest optionally using the frontal assessment battery and the trail-making test A. These can be particularly helpful in trying to differentiate the cognitive pattern of idiopathic normal pressure hydrocephalus from coexisting conditions like Alzheimer's disease.
That makes sense. Finally, urination. Often subjective. How should we assess improvement after the TAP test?
The Hellstrom Idiopathic Normal Pressure Hydrocephalus Scale, specifically its urinary component, was the most common tool identified in the review. For the TAP test itself, the practical recommendation is to optionally use avoiding diary.
Avoiding diary. For how long?
Documenting frequency and urgency for a period before the TAP and then continuing for up to 48 hours afterwards. However, there's a really important caveat here.
What's a limitation?
The consensus group explicitly stated that we currently don't have a defined minimum threshold for improvement in just urinary function or just cognition that would be sufficient on its own to warrant surgery.
I see. So while we assess all three components, the decision to shunt still hinges primarily on that gait improvement.
Exactly. Gait response remains the gold standard metric for determining shunt candidacy based on the TAP test.
Okay, that gives us much-needed clarity on performing and interpreting the TAP test. But this leads us into part 3, the somewhat sobering reality of treatment failure and long-term outcomes. A positive TAP test predicts short-term response, but the data suggests it's not a great predictor of long-term success.
That's right. And the Sauer-Jussingham study provides some crucial long-term follow-up data on this. They looked at 65 patients who received ventriculoperitoneal shunts and followed them for a pretty substantial average time, about 3.75 years.
And their key contribution was categorizing patients based on when they stopped responding, wasn't it?
Precisely. They didn't just lump responders and non-responders together. They identified 3 groups.
What were the groups and their proportions?
The largest group, unfortunately, were the early non-responders. These patients, about 54% of the cohort, failed to show sustained improvement within the first 6 months after getting the shunt.
Over half failed early. What were the other groups?
The second group, about 15%, were late non-responders. These patients initially improved, but then showed symptom declines starting after that first 6-month mark, continuing out to about 3 years.
And the rest?
The remaining about 31% were considered the true long-term responders, maintaining benefit over the follow-up period.
An early non-response rate of about 54% is quite high. It really makes you question the pre-surgical selection process. Did that study find any baseline factors that predicted who would end up in which group, early failure, late failure, or responder?
They looked closely at baseline characteristics. Things like cardiovascular risk factors, hypertension, diabetes were actually very common across all groups, present in about 95 to 100%. So those weren't helpful differentiators.
What about dementia? Was that more common in the non-responders?
Dementia prevalence was very high, about 100%, specifically in the late non-responder group. However, when looking across all 3 groups, baseline dementia prevalence wasn't a statistically significant predictor overall. Only time disorientation showed a significant difference, being lower in the responders.
So common clinical factors didn't really separate the groups well. What about the TAP test result itself? Did a stronger positive response on the TAP predict better long-term outcome?
This is perhaps the most crucial and clinically challenging finding from that study. The degree of improvement, or even the specific pattern of improvement seen immediately after the lumbar puncture, did not significantly predict who would be a long-term responder versus a non-responder.
Wow. So the very test we rely on to decide if we should shunt doesn't tell us much about whether that shunt will provide lasting benefit.
Essentially, yes. A positive TAP test confirms short-term pressure sensitivity, but it offers little guarantee of sustained long-term clinical improvement. It's a major clinical pitfall.
This lack of long-term predictive power often leads clinicians to try adjusting shunt valve pressures when patients start declining after surgery. Was that strategy effective in this cohort?
The study tracked this meticulously. Overall, there were 131 valve pressure changes made during the follow-up period, occurring in about 31% of appointments.
So adjustments were common. Did they help?
Not really. Despite all those adjustments, only 17 of them, that's only about 13% of the total adjustments, were actually followed by any noticeable clinical improvement.
Very low success rate for adjustments. How did this look specifically in the non-responder groups?
Adjustments were actually made more frequently in the non-responder groups, suggesting doctors were actively trying to salvage the situation. However, these adjustments proved completely ineffective in stopping the decline in the early non-responders.
And the late non-responders.
For the late non-responders, the adjustments sometimes seemed to slow down the symptom progression slightly, but they still didn't halt the overall deterioration.
So the evidence suggests that for most non-responders, fiddling with the valve isn't the answer. The problem lies deeper.
That seems to be the case. It points towards underlying pathology that valve settings alone can't fix.
Which brings us to the pathophysiology of non-response. If shunting doesn't help over half the patients long-term, especially that large early non-responder group, what's the leading theory for why?
The prevailing theory revolves around irreversible brain damage. The idea is that these early non-responders likely represent a more advanced stage of the disease process.
Advanced in what way?
In these patients, it's thought that chronic mechanical compression from the ventricles, combined perhaps more importantly with chronic cerebral ischemia in the paraventricular white matter, has led to damage that's simply gone too far. You get neuronal loss, gliosis,
And that results in?
ultimately increased brain stiffness. The brain tissue itself becomes less compliant, more rigid. At that point, even if you divert cerebrospinal fluid and lower the pressure gradient with a shunt, the tissue is too structurally compromised to recover function.
Increased brain stiffness. Is there any way to measure that non-invasively before surgery?
Yes, this is where magnetic resonance elastography, or MRE, is showing real promise. MRE is an imaging technique that can actually quantify tissue stiffness.
And have studies shown increased stiffness in idiopathic normal pressure hydrocephalus using MRE?
They have. MRE studies are demonstrating that cerebrum stiffness does increase as idiopathic normal pressure hydrocephalus progresses. So MRE potentially offers an objective marker of this advanced, possibly irreversible stage.
That could be huge. How might a neurologist use MRE in practice? If the MRE shows high stiffness, but the patient still has a positive TAP test, how do you make the call?
That's the million-dollar question, isn't it? It highlights the potential conflict between short-term physiological response, the TAP test, and longer-term structural prognosis, MRE.
So the potential future is using MRE to identify those likely early non-responders.
Exactly. If a high MRE stiffness reading could reliably predict that about 54% group who will fail within 6 months, despite a positive TAP test, we could potentially avoid subjecting those patients to an invasive surgery that won't provide lasting benefit.
It suggests a move towards a more integrated approach, combining anatomical markers like callosal angle, the physiological TAP test result, and structural data from MRE to make a more informed shunting decision.
That seems to be where the field needs to head, yes. Using all available data to refine patient selection.
Okay, which leads us logically into part 4. Looking at the definitive evidence for the effectiveness of the treatment itself when it does work. The PENS trial, published in the New England Journal of Medicine, is the key study here, right? The highest level evidence.
Absolutely. The PENS trial is crucial because it was a double-blind, randomized, placebo-controlled trial, the gold standard design.
How did they select participants to ensure they were studying patients likely to respond?
That's a key point. Participants were only included if they had already demonstrated improvement in gait velocity after a temporary cerebrospinal fluid drainage procedure, essentially a positive TAP test. This ensured they were testing the shunt's effect in a potentially responsive population.
Smart design. And what were the two randomized groups? The intervention versus placebo.
Participants were randomly assigned to one of two groups. The active group received a ventriculoperitoneal shunt with the valve set to an open setting, specifically an opening pressure of 110 millimeters of water.
And the placebo group.
The placebo group also received a shunt, but the valve was set to a very high opening pressure greater than 400 millimeters of water, effectively rendering it closed or non-functional. This allowed a true comparison between active cerebrospinal fluid diversion and a sham procedure.
Okay, let's look at the results, starting with the primary outcome. The change in gait velocity at the 3-month mark.
Yeah.
Did the active shunt work better than placebo?
Yes, definitively. The results were highly significant in favor of the open shunt. Patients in the open shunt group showed a significant increase in gait velocity with a mean change of 0.23 meters per second.
And the placebo group.
The placebo group showed almost no change, a mean change of just 0.03 meters per second.
So a clear, insignificant difference between the groups.
Absolutely. The treatment difference was 0.21 meters per second, and this was significant. The PNS trial provides that level 1 evidence confirming ventriculoperitoneal shunting effectively improves gait velocity in TAP test responsive patients.
What about the secondary outcomes? We mentioned earlier the benefit seems focused on mobility. Did balance improve significantly as well?
Yes, balance, measured using the Tinetti scale score, also showed a significant benefit. The open shunt group had a mean improvement of 2.9 points on the Tinetti scale,
Compared to placebo.
compared to only a 0.5-point mean change in the placebo group. So again, a significant difference favoring the active shunt for combined gait and balance.
Okay, mobility and balance clearly improve. Now, what about cognition and urinary incontinence? These are often major concerns for patients.
This is where the results align with what many clinicians observe. The improvements seen in cognition, measured by the Montreal Cognitive Assessment Score, and urinary symptoms, measured by the Overactive Bladder Questionnaire Score, were not significantly different between the open shunt group and the placebo group at 3 months.
No significant difference. What were the actual changes?
For the Montreal Cognitive Assessment, the open shunt group improved by a mean of 1.3 points. While the placebo group improved by 0.3 points, the difference wasn't significant. For the Overactive Bladder Questionnaire, the open shunt group improved, score decreased, by minus 3.3 points versus minus 1.5 points in the placebo group again, not a significant difference.
So the PNS trial confirms. The primary, reliable benefit of shunting seen at 3 months is clearly in gait and balance, but not significantly in cognition or incontinence for the group as a whole.
That's the clear message from this high-level evidence. It really reinforces that if a patient's main problems are severe cognitive issues or isolated incontinence without major gait impairment, the justification for shunting based on current evidence is weaker, even if their magnetic resonance imaging looks suggestive.
A crucial point for managing patient expectations. Lastly, what about adverse events? Shunting is invasive? How do the risks compare between the groups?
The adverse event data really highlights the trade-offs involved. On the plus side for the shunt, significantly fewer patients in the open shunt group reported falls, about 24% compared to about 46% in the placebo group.
So improves mobility translated into fewer falls. What about the direct surgical or pressure-related risks?
Those were higher in the active treatment arm, as expected. Subdural bleeding occurred more often in the open shunt group, about 12% versus only about 2% in the placebo group.
12% subdural bleeding is not insignificant. Any difference in cerebral bleeding?
Cerebral bleeding rates were low and similar in both groups, around 2%. However, pressure-related side effects were definitely more common with the open shunt. Positional headaches affected about 59% of the open shunt group compared to about 28% of the placebo group.
Almost 60% had positional headaches. That underscores the need for careful valve management post-op.
Absolutely. The PNS trial confirms the mobility benefit is real and significant, but it comes with tangible risks of bleeding and pressure-related complications that need to be discussed thoroughly with patients. It circles back to the importance of careful patient selection.
It certainly does. This has been an incredibly detailed look at idiopathic normal pressure hydrocephalus, from understanding its prevalence right through to the nuances of treatment response and the best evidence we have. Let's wrap up by reiterating that practical summary for clinicians.
Okay, first key point. Maintain a high index of suspicion. The incidence seems much higher than we used to think, around 4.8 cases per 1,000 person years in older adults. Don't dismiss potential symptoms lightly.
Second, standardize your large volume TAP test. Remove at least 30 milliliters, ideally 40 to 50. And the critical outcome is a gait velocity. Look for greater than about 25% improvement on the 10-meter walk test. Remember to check at 48 hours if negative initially.
Third, use refined imaging markers. Prioritize the callosal angle. Cutoff 112 degrees suggests idiopathic normal pressure hydrocephalus, and the Z-Evans index, cutoff 0.31, over the standard Evans index for better diagnostic specificity.
Fourth, ventriculoperitoneal shunting works for gait and balance. PNS prove that. But be aware of the high non-responder rate, potentially over 50% early on. Consider advanced imaging like magnetic resonance elastography to assess brain stiffness pre-op, as it might predict non-response. Valve adjustments are often ineffective for early non-responders.
And fifth, remember that long-term follow-up is crucial. Late non-responders can emerge after 6 months, often associated with comorbid dementia, so even patients who respond initially need continued monitoring.
Excellent summary. Now for a final thought to leave our listeners with. We've seen the PANS trial objectively confirmed gait velocity improvement. Other work, like Ekblom's study on blinded video assessment, shows good agreement among raters on gait improvement, so our objective measures seem reliable.
But PNS also showed no significant early improvement in cognition or incontinence. This raises a really interesting question for the future, doesn't it? As we get better at diagnosis and prediction, how do we truly measure success beyond just walking speed?
Are we capturing what matters most to the patient's overall quality of life?
Exactly. What other novel, perhaps more patient-centric metrics could we or should we be integrating into follow-up? Things that capture those subtle improvements in daily function or well-being that might not show up on a stopwatch or a standard questionnaire. It feels like the next frontier in truly understanding the impact of our interventions in this complex condition.
A fascinating challenge indeed. How do we measure recovery in a way that truly reflects the patient's experience? Something to ponder. Thank you for joining us on this deep dive into idiopathic normal pressure hydrocephalus.